Hi, so today I will be talking about Paceman for lateral distal femur tumor. For the positioning, I can say the positioning is correct because firstly, the anterior and posterior margins of the medial and lateral femoral condyles are superimposed, demonstrating a true lateral projection. The second one, the long axis of the distal femoral shaft is aligned with the long axis of collimated exposure field. The third one, the distal femoral shaft surrounding soft tissue, knee joint and approximately 1 inch or 2.5 cm, the proximal tibia and fibula are included within the exposure field. Fourth, the patella is included in lateral profile as part of the knee joint with no evidence of rotation. Next, the distal femoral shaft and the entire extent of the tumor are centered within the exposure field with lesion margin clearly demonstrated. Next, the unaffected limb is excluded from the exposure field to prevent superimposition and unnecessary radiation exposure. Last one, adequate soft tissue detail is present to assess for associated soft tissue mass and extension related to the tumor. Next is alignment. The alignment between the X-ray tube and cassette cannot be determined because there is no superior and inferior border. Next, the alignment between the patient and cassette also cannot be determined. Next, the alignment between the X-ray tube and patient is correct because the center of collimation is at the center of the part. The central structure of this radiograph is mid-femoral shaft. For collimation, at the superior border, structure that should be included is 2 to 3 cm above the tumor. At the inferior border, structure that should be included is knee joint and 2 to 3 cm below the tumor. And at the lateral border, structure that should be included is full bone width and soft tissue margin. For exposure, a KPP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of thin structure, which is medial epicondyle and lateral epicondyle, can be seen. And the bony cortical outline of the thick structure, which is distal femur, also can be seen. The MAS used is adequate for detail and density. This is because the bony trabecular pattern of thin structure, which is medial epicondyle and lateral epicondyle, can be seen. Also, the bony trabecular pattern of thick structure, which is distal femur, also can be seen. For marker, right anatomical marker clearly visible and correctly positioned. Marker does not obscure the pathology. And for the aesthetic, the film used is 30 x 43 cm, which is lengthwise to demonstrate all the structure of interest. There is no artifact found on this radiograph. And for the name, there is no name, ID, date, or any projection information displayed. Thus, this radiograph is rejected and need to be retaken.